The next speaker now is Dr. Paul G. Urshep. Dr. Paul is going to talk on dementia and cataract surgery, a growing problem for all of us.
He is from the United Kingdom. He is the president of the UK Ophthalmic Society.
Thank you very much for the introduction. So my name is Paul Ursel. I'm from London. This just fits in very nicely with the first talk we had. If you looked at what people worried about, they worried about losing their sight, but even more importantly, they worried about losing their memory.
Could you be a little louder?
A bit louder? Is that better? Sorry. What people worry about is not just losing their sight, as we saw in the first talk, but also losing their memory. That was a higher percentage. So what is dementia? It's a loss of memory, thinking, concentration and language. And this is not the normal part of aging. Just because some of the people in the room, myself included, might not remember things so well, doesn't mean you've got dementia. It's a natural disease. Unfortunately, it's progressive. It doesn't get better. And the way to think about it, it's quite similar to AMD or optic neuropathy. If you've got glaucoma or optic neuropathy, it's due to raised pressure, or you've got macular degeneration. It could be caused by myopia, subretinal neovascular membrane, dry macular degeneration. Lots of different phenotypes lead to the same end process. And that's how you think about dementia. There's two main causes. The one we've all heard about is Alzheimer's, which is the deposition of amyloid, a tau protein in your brain, which destroys the neurons. And the other form is what we remember from when I was a lad at medical school, was called multi-infarct dementia, which is now called vascular dementia, which is a variation on microvascular disease, which affects the brain as a much more stepwise progression. And these two causes account for about 80% of dementia, about half each. Some Alzheimer's, some vascular, and some mixed, because you've got both. The rest is a variation on Alzheimer's, basically, in different parts of the brain. So people can get a thing called posterior cortical atrophy, which is where it affects the visual cortex. So you can look at a target and thinking, what is that? I know it's yellow. I know it's curved. Is it a train? No, it's a banana, because they can't process the information they're seeing. But there's a problem. If you look at the prevalence all around the world, it's largely due to the size of population. And you can see in India, you have as much dementia as you have in the US. And it's not a small problem. It's something you probably all will see in your practices every day. If you look all around India, this data is from a few years ago. There's a few things I want you to look at in this slide. First of all, it's variable. So if you're in the country as opposed to the cities, you've got different prevalences in different types of state. Secondly, if you look at the data of these productions, a lot of them are 20 years old. And thirdly, you can see it's all across India. It's not located in one specific place. So if you take that fact that the data is from a long time ago, it's the latest data I could find, which is from the World Dementia Report, which is about 10 years old. But in that report as well, they looked at what's going to happen over the next 15 years, and this is happening. And India, unfortunately, is having an increased incidence of dementia. It's happening in your country. And so you've taken a disease which is now prevalent, and it's getting worse. Why is it and it's a big problem. If you look at the actual cost to society in India, the amount of money it costs to look after people with dementia, because they have falls, they need care, it's as high as pulmonary disease, not quite as high as stroke, but it's certainly more important than depression and diabetes because of the impact it has on a global scale to someone's care. So that's kind of what's happening. Why is it happening? This is happening for very good reasons. The life expectancy is increasing. If you look at India compared to the rest of Southeast Asia, it's doing very well. Unfortunately, the fertility rate is dropping, and that means, which is quite good for eye surgeons, a large part of the population are over 65, but they're getting more than one disease. They're not just getting cataracts, they're getting dementia as well. Why is it happening and increasing in India? Unfortunately, it's due to the prevalence of cardiovascular disease. So we have a problem here of obesity, diabetes, hypertension, smoking. And those all lead into cardiovascular disease, microvascular disease, and vascular forms of dementia. This has been shown just recently in Nature from India, showing all these different factors are increasing the prevalence of it. A large problem as well is the fact that the family structure is breaking up as people are moving around into the cities, and they don't have the care support network they would have if they were living at home with their family. So what does dementia mean for us as eye surgeons? This is this is the sort of keystone piece of information to take home. This is a big project that was done in the UK, where they looked at people who have been diagnosed with dementia, and they went into their homes, and they just did an ophthalmic examination, and they looked at 700 people who've been diagnosed. And the thing to look at is a third of them were 618 or worse 612 or worse binocular, which they couldn't drive in the UK, This was their walking around vision. And all they did was refract them. And half of them had a refractive error. So you could just make half these people see better with just a new pair of glasses, which tells you they're not getting into the optometrist to get their glasses checked. Of that remaining lot, they looked at why they had poor vision. Half of that was cataract. So in people living with dementia, we can fix virtually all of it. 75% is just fixable. Take the cataracts out, fix their glasses. The reason why this happens is because if you think about our pathways for all our visual needs, they rely on you telling the physician what's going on. I can't see very well, I'm getting glare, I can't read. If you don't do that, the system falls over and doesn't work. So if you ask people what's going on, they don't tell anybody it's happening. People put down the visual decline due to the dementia, not their eyes, and people just don't turn up into the system. And getting a diagnosis of dementia is very bad for having cataract surgery. This is a group where they looked at people being diagnosed with dementia and they asked them, have you had your cataracts taken out? Yeah, 2 years ago, 3 years ago, whatever. And they age matched them with a control group, and they were the same. But then after the diagnosis of dementia, if you look at the bottom line there, the amount of cataract surgery in the dementia group fell off a cliff, whereas the control group still carried on having their cataracts. So being diagnosed with dementia means you don't get your cataract done. But unfortunately, cataract surgery can help dementia. Hearing aids is a big problem, and because it leads to social isolation, but also so does visual isolation. And this has now been shown from big retrospective analysis in the States, where they looked at about 60, 70,000 people. If they had their cataracts taken out, their chance of developing dementia dropped off. So they didn't get dementia. So what do you do? It's exactly the same discussion as have anybody else. Do the benefits outweigh the risks? Do you think the reduction in vision is due to the cataract? Is it likely to get worse? Is there a problem with glasses? If you're a +4 hyperope and you can't wear your glasses, you're functionally blind, simply because you're not +4. So that may well be a very good indication for surgery. Now, when we all see people with cataracts, we say, you know, you're not that bad at the moment. Come back when there's a problem, because you know that will be fine. The trouble is, if you do that and their cognition is getting worse, they won't come back when there's a problem. So what I'm saying to you is, if anybody gets into your clinic and you don't think there's much of a problem, the expression we have in London is fix the roof while the sun is shining. Take their cataracts out when you see them, rather than waiting for them to get worse. Practically, what do we do? Well, one of the problems is, particularly if they've got Parkinsonian-associated disease, is they can't keep their eyes open, they shut their eyes and squeeze and bell. So take the cataracts early before there's a problem. It's an easier procedure. I was taught at medical school that you shouldn't do a general anesthetic in people with cataract surgery, because the general anesthetic will make them worse, and that will balance out the improvements of their vision. That's not true. That data came from people having hip replacements and fractured neck of femurs and heart surgery, which was an hour-and-a-half operation with a lot of blood loss and a lot of recovery. For a little 5-minute cataract operation, that's been shown not to be the case. So you can safely give them a general anesthetic and it won't be a problem. And so it's a really good idea. Quick GA, do both eyes, done. If they're really bad and they're bedbound, probably not the case that it'll help them. A lot of the reasons why they don't get surgery is the carers are worried. So have a meeting with all the carers and saying, what's going on? How can we help? You don't have to worry about padding them after surgery. We can give them Depo injections. You don't need to give them drops. And that will often help the carers come to terms and be happy with them having their surgery. Now, we all make everybody emmetropic unless we're getting multifocal lenses. Now, multifocal lens in dementia is a whole other topic. I can talk to you about that for hours. But we make people emmetropic. But if their lives are they're housebound and all they want to do is eat and maybe read a little bit and they're not going out of the house very much, leave them -1. That means their world is in focus at arm's length, which is what they want to do. And if they can't wear glasses, they're still going to be able to function. And a lot of the time, you can't get them to read and do the assessment, and you do this a lot with illiterate patients, particularly if the people who are looking after the person with dementia haven't known them for very long. So what we do is we record a functional visual assessment. So this is Seema here. Seema can cook, she can wear glasses, and she enjoys telling people stories. You write that down, and then Seema comes back in a year's time. She's not cooking, she's not talking very much. This may be because of the dementia, this may be just she can't see. So today, when you're looking after people in your practice here in India, 1 in 5 people over 80 are living with dementia. That's a big number. A lot of them will not be able to see simply because they haven't got the right glasses on. And if you take their cataracts out, you're going to make them have a better prognosis for their dementia. But they don't get treatment because they don't come to see you. The people who are looking after them don't think it's worthwhile. we don't think is worthwhile, which is ridiculous. And we put it all down to the dementia rather than their cataract. And we know that cataract surgery will improve their life. Falls, if you look at the dementia literature, is a huge part of the problem. So we don't want them to have falls. And we need to change this. Thank you very much. And if you're coming to London, put the slides back up. If you're coming to London in November, it's the 75th anniversary of Ridley putting the first ever implant in.
Thank you very much. Was this data mostly from India? I find that you have taken the data mostly from the Indian data. So does it include the data from the UK, or what is primarily this data has come from India?
The prevalence and incidence data I have from the UK, but I changed it for India for this talk. So this is what's happening in your territory in India. It is there. It is happening. The data about the surgical treatment is kind of clinical data from our own experience, and the incidence is European data, but I don't think it'll be very much different over here.
So the surgical intervention is more in the UK. The data is from the UK rather than from India, isn't it?
Oh yeah, you do. Your incidence of cataract surgery is higher than ours.
But for dementia, I don't know what is the data. We don't have the data for patients with dementia, the cataract surgery in dementia. I don't think we have it.
We don't have that data, but I don't think the problem will be any different. I think it's a societal problem that people don't present to us for whatever reasons, and then they don't get their surgery because we say come back when you're worse. And that's why it certainly happens in our practice in Europe. I've been trying to change it, and imagine it'll be happening worldwide for the same reasons, not just India, but everywhere.
Thank you very much.
Thank you.